Just said it. Okay. All right. Look at that. All right. Well, welcome everyone. I know we're a few minutes past the hour, but thanks everyone for, taking your lunch break to join me and the Yuvo and the Doc Health team here. Really excited to get into the discussion today. We're going to have a lot of really interesting, talking points around Medicaid and federally qualified health centers. But first, I'd love to give the floor to Doc Health. Doc Health has been gracious to sponsor this webinar, and they are a firm that has been on my radar for a while, and they're a HIPAA-compliant task management and workflow automation firm for providers. So I'm really excited. Mike, would love to give you the floor and ask you to talk a little bit more about Doc Health.
Thank you, Blake. Appreciate it. Thanks everyone for joining today, and I appreciate the opportunity. So I'm Mike Doctor, co-founder, CEO of Doc Health. I'm a gastroenterologist by trade, and we're just really excited to be part of this conversation. Frankly, mostly to learn about FQHCs and all the great work they're doing. Our focus is really on task management, workflow automation, particularly on the administrative side of care, and we hope to sort of raise awareness of the administrative burden of care. I'm sure most clinicians are well aware of the administrative burden, but really not any great ways to solve for it. So again, our work is really focused on bridging the gap that exists between the clinical intent and the administrative work that needs to be carried out, creating simple tasks and workflows and automating as much of that as possible to create more efficient organizations, more accountable systems, and more highly reliable care. So again, I appreciate the opportunity. Looking forward to learning a lot more about this whole FQHC world that we're just learning, just beginning to learn about.
Thanks, Mike. Yeah, really appreciate the Doc Health team sponsoring this event. And now would love to, turn the discussion over to our panelists who are joining us from Yuvo Health. Guys, I'd love for you to intro yourselves. Maybe Cesar, we could start with you and go from there.
Sure, sounds great. Pleasure to meet everyone. I am Cesar Pereira, co-founder and CEO of Yuvo. Oh, did you want me to give more in the meantime? I thought.
No, if that's all, that's great. That's great. Selassie, why don't you go ahead?
Oh, sure. Good morning, everyone. And Blake, thank you for having us. My name is Selassie Dow. I'm the Chief Operating Officer for Yuvo. Looking forward to exploring some of the questions and going through the discussion around FQs and how we can support them now and in the future. Thank you.
Awesome. And then Laura, you're up next.
Hi, everybody. I'm Dr. Laura Council. I'm a family and preventive medicine physician and the Chief Population Health Officer here at Yuvo. I have been a practicing doc and caring for these populations, both as individuals and in aggregate, and happy to talk more about the kind of care that we're doing in Medicaid and in the FQHCs.
And Lauren, last but certainly not least.
Thanks, Blake. Hello, everyone. Thank you for joining us today. Lauren Anthus, I'm the head of policy and programs at Yuvo Health. Have a big background in public policy. Mainly, I'm a recovering Medicaid reimbursement specialist. So really excited to get the conversation going today to talk about more about how Yuvo really is a policy solution that satisfies a lot of our transition towards value-based care over the last couple of decades. So thanks, Blake, for hosting this.
Yeah, no worries. And you say Medicaid reimbursement specialist as if it's a bad thing.
It depends on who you're talking to and who you're reimbursing.
Fair enough. And forgot to mention this prior to the intros, but for the audience and the folks that are on the call, our events team will drop in a link to an app or a web browser called Slido, where you guys can ask questions and vote on questions for us to talk about at the end of the discussion. So we will have an audience Q&A component for anybody who's interested in just asking the Yuvo Health team. That should be in the chat right now. Great. Well, Cesar, would love to just jump into the Yuvo Health story. If you wanted to give background on yourself and how Yuvo was formed and the business model and how everything works together, and would love for you to take the floor.
Sure thing. Before I talk about the story, I think it might be important to ground people on like what we do and for who. What Yuvo Health is essentially we act as a risk-bearing entity for federally qualified health centers. And we built as such out of necessity, not out of like, oh, this is an interesting white space that we want to be able to exploit. We did it out of necessity. And here's why. So federally qualified health centers, or FQHCs, there's about 1,400 of them across the US, and they are specifically regulated by the Health Resources Services Administration to provide primary care and wraparound services for individuals in medically underserved areas, regardless of their ability to pay. And you can imagine that given that mandate, that especially in the communities that they serve, which are often underinsured or uninsured, they are in many cases not only the primary access point, but the only access point for primary care service. Those 1,400 FQs serve over 30 million people across the US. But as I mentioned, there's 1,400 of them. There are 4,000 medically underserved areas across the US. So you can kind of do the math there to realize that there is an access problem. I'm sure I'm preaching to the choir, everyone here knows that there's an access. According to HRSA, that's about 25 million people that need access to primary care that do not have access to an FQHC. If you're to ask any FQ, why don't you serve more people? They're not going to say it's because they don't want to. They're going to say because they simply do not have the capacity to do that. And that is because they're not financially sustainable. They don't get paid enough for the work that they do. And that's why Yuvo is here. We were mission built specifically to support FQs, given the amazing and critical work that they do to serve historically underserved communities and keep them healthy. And we need them to thrive. And not just us at Yuvo, but us as a society needs them to thrive. And where we see a true opportunity is through value-based care, because everything that value-based care is going to highlight is everything that FQHCs were already mission built to do. They do integrated care delivery models. They do address social determinants, social drivers of health just as much, if not more, than clinical services. They do all of these things in a community-centric, patient-centric way that keeps them healthy and keeps them thriving. So they should get credit for that, but they don't, because there are numerous barriers that stand in the way of participating meaningfully in value-based care. So that's why we're here. And then in terms of how this came to be, it's also deeply personal to me because I was an FQHC patient myself. So growing up in the east side of Detroit, I had no healthcare insurance for the vast majority of my childhood. So FQHCs were my primary care provider. And currently I'm very fortunate that I have access to an FQ because there are 25 million people that don't. But it should never be a matter of luck or fortune that you have access to primary care. You definitely should not be going to the ER for primary care. That should not be the only option. So that's how we built. And I come from 20 years of experience in healthcare, majority of that doing value-based care strategy, predominantly on the Medicare side, because most of the innovative models have been in Medicare. There may be smatterings here and there of commercial, but very few have been built to support community-based healthcare organizations like FQHCs, particularly those that are serving predominantly Medicaid populations. And that's really who we know deserves it and needs it the most. So that's how we came to be.
Yeah, thanks, Cesar, for that background. I mean, I think that, you put it pretty plainly, but there is a clear need here. And you mentioned necessity. But I'd love for you to expand on, FQs are it seems so well equipped to, you mentioned the wraparound services and the comprehensive primary care. what's been the roadblocks to this point, and kind of what does Yuvo unlock to get them from A to B and unlock that value that they need to sustain themselves? Would love to hear more about like the unique challenges FQs face as far as Medicaid or things that you're seeing.
Yeah, so if we're talking about it solely from Medicaid or solely from a reimbursement standpoint, value-based care is a great opportunity if you qualify for it. And federally qualified health centers, for the most part, don't qualify, as in many are subscale. There are minimum panel requirements in order to qualify for taking on risk with a health plan. And as you can imagine, FQHCs are not the size and scale of a large health system. They don't have 300,000 lives attributed to them that they can then take on and meaningfully, manage risk for that population. It's relatively small. The second is, it's really costly to be able to support in that model. It's not just about getting credit for good care. You're now taking on risk for a population that you don't have full visibility into. So you need data, you need systems, you need analytics, you need to do a whole lot to manage that risk with population, especially since FQHCs only represent 4% of the cost for that patient. So 96% of the cost goes outside. So you need visibility into that. If you don't have visibility, you can't manage that care, right? And then it's not cheap. And then the third, but the most critical piece is FQHCs are not able to take on downside risk. And this is an important piece. They are regulatorily prohibited from taking on downside risk. And from a policy standpoint, I understand the well-intention of they don't want, policymakers don't want FQHCs to make less than what they're currently making, potentially. But the downside of that is then they don't have the opportunity to make significantly more. That's difficult because FQHCs are simply not making enough to be able to thrive, right? So those are the main challenges as it relates to like meaningfully participating in value-based care. And those are the reasons why I say that we were built by necessity, right? Not as a good to have, because again, we can act as that risk-bearing entity. We're the ones that are taking on and absorbing 100% of that downside risk. It enables us to open that door meaningfully to FQHCs to actually get paid more.
And Blake, I would add to what Cesar is saying, which is that sort of dovetails into what are the solutions and value props that we bring to the forefront, right, to support FQs do this body of work. Given all the things that Cesar indicated, Yuvo has the operational engine and the ability to aggregate FQHCs and then become the front of the spear in getting or activating these contracts with MCO, with payers, so that they can get the right incentives and the right resources along the risk continuum. So that's sort of number one of our value prop. What is the solutions that we bring? Well, we can engage MCOs and payers and secure these incentivized agreements that allow FQs to really ingest the incentives for the work they've already been doing across the risk continuum. And also, we also can bring the solutions, right? It's not just about bringing the contract, but it's deploying the solutions that allow them to be lifted up of the challenges they have, whether it's human capital or human resource, whether it's revenue, as Cesar talked about, whether it's a technology wraparound infrastructure, and the population health infrastructure that allows them to really thrive within value-based care. That's something that I believe hasn't historically been available to FQs, and so they've been left behind. And that's a bombastic idea, but they have been left behind. It's only up till recently when, in my opinion at least, when we had an existential threat to our communities and the world, that we really began to see where are the safety nets within our communities that are driving care, FQs, able to immunize about 65% of our population and get us to herd immunity. So the work, as Cesar described, is important. It should have been happening a decade ago, 2 decades ago, but we're glad that Yuvo is at the forefront in delivering those services.
Yeah, that's fantastic. So lastly, I would love for you to expand on, so as I understand it, what you just described, so FQs themselves cannot take downside risk, but Yuvo contracts with the FQs separately to take on downside risk and provide them
Absolutely.
with kind of technology. Okay, interesting. Could you expand on kind of how those contracts are structured, or what the arrangements are, like the metrics to hit, those sorts of things?
Absolutely. I mean, at a high level, they are fairly designed to ensure that all the stakeholders within the contract are arriving at a win-win. So it starts with making sure that we can meet the membership threshold. And since I talked about it, we're able to aggregate FQs because they don't have sort of the membership density that allows them to ingest these contracts. So we're able to do that on their behalf. We're able to engage in agreements that provide metrics that we know are realistic and that can be achieved by FQs. We don't want to showcase terms of agreements that they cannot achieve. And then we're also able to ensure that these terms allow the FQs to access the most value and meaningful resources and incentives within these contracts. Now, there are specific numbers. If you talk about membership threshold, medical loss ratio, there are quality gates associated with these contracts. So within these contracts, you have to hit certain quality gates in order to unlock shared savings. But this is the most powerful part of what we do, which is unlike where I came from, servicing and supporting commercial, as I talked about, and Medicare Advantage work. My work in 20 years has been building networks primarily in that infrastructure. In this national consciousness, our contracts are designed to also impact the social needs of our FQs and their patients. And so these contracts have a layer in there that says we can build an infrastructure to support the social needs of our consumers, whether it's transportation, whether it's housing, whether it's food deserts and nutritional issues, whether it's childcare, because we believe the bet we're making, and I would believe the national consciousness is making the same bet, is that if we're able to solve those issues and those problems, then the members for which we have set up this, our Yuvo and certainly the FQs, can then have the space and the headroom to focus on their care. Because when they're focusing on social needs as well as their care, oftentimes what takes precedence, Blake, is their social needs. I've got to get out of the under the bridge and get roof over my head. I've got to get food on the plate. And so that's the infrastructure that is uniquely important to the contracts that we construct. It has a social component that allows us to support our patients in this environment.
Yes, Loss, I love that response. And I think that's a great segue over to Laura. Laura, I'd love to hear more about kind of, who Yuvo is partnering with and kind of like the provider perspective, and, how the Yuvo team and, enabling FQs helps, unlock better patient outcomes, better patient care, less administrative burden for providers, to just speak to those sorts of things. Would love to hear your perspective.
Yeah. So the health centers, because they're serving disenfranchised populations, as they have become disenfranchised from the richness of the health ecosystem themselves. And so in addition to giving access to the contracts, which by us taking on the downside risk, it gives them access to a greater share of that upside risk, more than they could possibly make in fee-for-service. We also connect them to two other pieces. One is the data ecosystem. And we know that teams take better care of patients when they know more information about those patients. And when those teams are spending their clinical time caring for the needs of the patient, looking at the patient and family's goals, rather than spending their time running around trying to figure out when was the last hospitalization or what the current medication list is. So part of our solution is not just engaging them in the contracting side, but engaging them in that data ecosystem side, both at the point of care where we can offer tools and at the back end where we can offer dashboards. Remember, we take care of, in primary care, we take care of both individual patients according to their customized goals and needs, and segments of the population according to the needs that they do. And we titrate our interventions both for the individuals and the populations by using data. The third key piece of it is transforming the operations. Now, as everybody knows, primary care is drowning. There is too much to do and too few people to do it. and a third of primary care docs are going to retire in the next 5 years. We cannot rely on physicians to be the solution for this population. And so in value-based care, we transform the way that a clinic works and the way that a clinic practices from being reliant on just the physician as the source of revenue to being reliant on the entire team as the source of revenue. In value-based care, because you are trying to create value with quality at lower cost for your whole population, every employee at your health center becomes a revenue generator. And the way that we work with the health centers is picking off projects one at a time and using standard, Lean Six Sigma QI processes that other rich health systems have done for a long time. We do that and help them grow their own capacity to further engage their team members in delivering more of the care, thus decreasing the burnout of the physicians and ensuring a longer physician tenure at the FQHC.
Yeah, great insight there, Laura. I'd love to expand more kind of like on the operations piece. I feel like in general, FQs are known to be relatively understaffed. Just, it's kind of the nature of the beast. How have y'all been able to manage that from the Yuvo perspective and, bringing in your care team, or how is the dynamic playing out there?
Yeah. I mean, part of it is the framing, right? When we frame from a perspective of scarcity, all we see is scarcity. What FQHCs have done for 50 years, which is truly remarkable, is that they frame from a perspective of abundance, and they tap into every single person in that community who knows how to get something done. So yes, is there a 30% staffing shortage at FQHCs compared to where they want to be? Absolutely, that is a thing that not only happened during the pandemic, it happened before the pandemic, and quite frankly, it's not going to change. They cannot compete with the salaries that physicians and nurses especially are getting at other places. So what does Yuvo do? Yuvo goes in with the framework of abundance, does an assessment and says, look, there are so many things that you want and can do for your patients that don't require a clinical degree. You don't need a nurse to do all of these things. Let's figure out who in your community wants to work here and who can ask some of these questions. At a previous organization, we were very successful in figuring out that our front desk staff, especially those who really live in the community and know the patients mom and know the patient's kids, those people are much better equipped to ask screening for social determinants once they have some training and once they know that when they find out the problems, they're not going to be left alone to deal with it. They have a team around them to help deal with it. But they're very effective at asking the questions. So some of the ways that we deal with these staffing shortages is the traditional QI methods of who absolutely has to do this job. Let's let the physicians, the nurses, the licensed social workers, dentists do only the things they have to do, and let's build that team around them of unlicensed people who maybe they will become licensed, through the course of their career. But at this point, they're committed to the community, and they can really help take some of these processes. And so through that task shifting, we're finding more capacity even without adding bodies.
Yeah, that's fascinating. I love kind of like the frame shift, like shifting from the scarcity mindset into abundance. I haven't heard that before, so I appreciate that commentary. Cesar, I'd love to shift the conversation over. I see just kind of some general comments around, you mentioned kind of FQ aggregation and scale. I'm curious, are there certain markets that are more kind of friendly for scaling right now, or kind of how do you think about the growth of, the Yuvo platform?
Yeah, so since the majority of the patient populations that's served by FQHCs is Medicaid, then we think about it scaling state by state. And because what we're talking about is value-based care, then we have to, we're necessarily limited by the states that enable Medicaid managed care. So not every state has Medicaid managed care. Majority do. And then for there, then we scale from that point on of particularly those that through Medicare or through state Medicaid reprocurement enables, or through like 1115 waivers enables alternative payment models within Medicaid for Medicaid providers. So then those are the areas that become really great opportunities and testing grounds for FQHCs to participate meaningfully in different value-based care models if only they had an aggregator and partner like Yuvo to support them. So those are kind of how we thought through where we can then scale appropriately. But remember too, FQHCs represent about 20 to 25% of all Medicaid patients go to an FQHC. So there's meaningful opportunity for any FQHC, urban or rural, in the states that enable alternate payment models for Medicaid. So that's kind of how we think about it. But it's important that we recognize that our model has to also be able to conform to different state regulations and different types of models around how Medicaid is provided and alternative payment models are delivered.
Yeah, that makes a lot of sense. And Lauren, I think that's a great segue over to you. One, I'd love to hear kind of just a little more detail and color around kind of those, Medicaid programs at the state level. And then two, how is the wind down of the public health emergency and Medicaid redeterminations? I know that's a whopper of a question to ask, but what are y'all seeing about, what are you seeing for redetermination?
Yeah, that definitely is a whopper, but I'll try to be your Burger King, so to speak. So let me start maybe with a little bit of a premise. When you look at Medicaid as a program, it's a big part of state economies. If you look at any state budget, it varies anywhere to 20 to 40% of all expenditures that are facilitated through state legislative budgetary cycles, right? In the state of Ohio, which is one I'm most familiar with, for example, we spend about $63,000 a minute on our Medicaid program. And out of that group, about $1 in $3 that we appropriate in total flows through a managed care program, and $1 in $6 the state appropriates flows through singularly CareSource. So when you think about Medicaid as an economic force, it's significant. It's 4% of our state's GDP. 1 in 4 Ohioans are covered through the program. And so from a Medicaid director standpoint, right, or from a, let's say, a policy perspective, really what you're trying to do is risk manage, because our system has been built on fee for service. We have incentivized systems that incent disease management, not wellness. We've incentivized acuity. We have not incentivized primary care. And so for that reason, a strategy that centers federally qualified health centers disproportionately is going to be a good policy strategy generally. And the challenges that are usually faced are they're small. They don't get the same policy resources that a lot of organizations get through, say, like the automatic reimbursement of capital expenses or IT expenses or graduate medical education dollars, that sort of thing. They don't get supplemental payments oftentimes that maybe larger systems get. And so you're disadvantaged in a privatized managed care environment because you don't have the scale or the organizational wherewithal. And that's essentially what we're trying to do, is build the infrastructure to meet that demand that's being sort of put, that has a lot of pressure on it, put in a bipartisan way on state governments, because quite frankly, it's a lot of money that we're spending and we're not getting very good outcomes. Now, talking about the role of the public health emergency, right now at this moment, or at least maybe about 4 or 5 weeks ago, the United States had the lowest uninsured rate in its history. And that's because the public health emergency had a number of provisions in it that, number one, supported states with additional federal money, but also ensured that people who had coverage through Medicaid programs maintain that coverage, which makes sense in a pandemic. Medicaid is countercyclical. You usually spend more money when the economy goes down because people might lose their jobs. And also you want people to get access to, immunizations, and if things get worse, hospital care, and then that they don't end up in significant debt or even worse. So with all that in the background, we're now at the point of unwinding. And so it's going to be a state by state thing, but we're going to see millions of people potentially lose coverage. And I think, first of all, what the state's machinery, whatever any individual state's machinery is around eligibility, is going to determine a lot, but so too are federally qualified health centers. In some states, they have presumptive eligibility. They work directly with individuals on maintaining their eligibility. In other states, that's not necessarily the case. But regardless, if you are a person who's on the Medicaid program, you may still walk through your doctor's door and seek out care. And these are the types of institutions that are going to still serve them. So in a lot of respects, what we're offering here is sort of protection against some of those negative impacts, and also an efficiency solution for states, because, you know, if the economy takes a different type of turn and Medicaid expenditures go up, there's a lot of pressure that's going to be put on state budgets. So those models that provide some financial wherewithal are going to be very attractive from a policy perspective.
Yeah, very, very interesting. I feel like you just keep hearing about kind of like the Medicaid redetermination and like doom and gloom, but it's interesting to hear that you guys kind of have some tools in place for that. So that's cool to hear. Let's see, any other questions for you? Lauren, I'd love to field this, just maybe one more question for you, and then maybe we can look at the audience questions from there. But or maybe this is just for everyone on the panel. But what policies or rules kind of would you guys like to see changed? You know, you got your choice of the cherry tree or whatever. What would you kind of like to see changed in the near future?
Wow. Well, I'll start, and then you know, I'd love anyone else to sort of like chime in from our standpoint. But I think as states are thinking about their Medicaid programs and they're thinking about cost efficiency, I would say the things I don't want to see are restrictions on eligibility. We know that that doesn't work. We know that when you make programs more restrictive, typically what happens is people cycle in and out. They don't necessarily have economic mobility to move out of the program. So usually when you have more continuity and coverage, you see people more economically successful later in life, less governmental expenditure, so on and so forth. I think what I would rather see, just from a fundamental standpoint, is policies that are supportive of the type of work that we're trying to do, that encourage taking on downside risk, that encourage primary care as being a more valuable thing in the reimbursement construction of state policies. And then, of course, on the federal level and on the state level, I mean, here's the thing, clinical care only accounts for about 20% of outcomes. It's all this other stuff. So when we think about, you know, the social drivers of health, I think there are other policies I'd like to see more of around better transit, better housing, better food security, so on and so forth. But as we develop those policies, also enabling additional policies that allow us in a value-based environment to help finance innovative solutions and don't create barriers to collaborate between organizations like FQHCs and community-based organizations like food banks to commonly case manage things. I think we can do a lot of that depending on what we're talking about contractually, but I'd love to see more policies that not only encourage those systems of support so they're more readily accessible to people individually, but they become a more regular part of how our system is organized so that we're not continually treating everything like an emergency room, whether that's medical or not.
Awesome. Thanks, Lauren. Great. Well, I think that, you know, we can hop into some audience questions at this point. Looks like there's a couple that are similar. So one, does Yuvo contract with FQs in rural areas? And then two, what markets are you in?
Happy to answer that. Yeah. Oh,
go ahead, Sila.
So yes, we contract with any and all FQHCs, urban, rural, it doesn't matter. We want to support any and all FQHCs. And how it works then is FQHCs are then able to then get value in the aggregation. So there's network effects associated with this, and there's more FQHCs equals more patients that are attributed to these risk-based contracts, which means more negotiating leverage that we have with health plans in order to make sure that we have better terms, and more patients that we can spread risk around across, right? Which is really the name of the game in terms of risk mitigation. In terms of the markets that we're currently operating in, that is New York and Ohio, and would love to continue expanding our support model to as many other states that want us and need us.
Very cool. Here's another interesting one. So this might be more of a long-term question, but it's FQs today, but are there any plans kind of in the future to expand to other kind of like provider groups with large Medicaid populations?
As you can imagine, FQHCs are very uniquely designed and regulated and have a very unique mission relative to other primary care providers that are independent practice. And that's really what resonates with us. And as you can imagine too, that's the reason why we were built to support those FQHCs. So I'm never here to predict the future, but I can say that we were mission built very specifically to support FQHCs. But mind you, these FQHCs serve almost 33 million people across the country. So there's certainly a lot of opportunity there to be able to impact millions of lives by uplifting our FQHCs.
Yeah, absolutely. Here's a good question from Heather. Our FQHC hasn't been profitable since its inception 40 years ago. How would Yuvo and the Yuvo team help us grow our business in a way that's sustainable?
Oh, okay.
Heavy hitter.
I think all of us can chime in on here in different ways, right? And I think that's the beauty of enabling this under value-based care is by participating in this type of model, there's multiple revenue levers that we're able to pull, whether that be from a clinical care standpoint, whether that be through value-based care dollars, whether that be leveraging policy in our favor. So I would love for my team to be able to kind of answer that under those three different lenses.
Yeah. I can go ahead and start. I mean, I think that's a great question because that's the kinds of questions we want to hear in this forum to assess how your audience are ingesting the information and where the needs are. Honestly, from the very beginning, it's about assessing an FQ like your audience mentioned. What is the current infrastructure of the association with managed care organizations to ingest value-based contracts? What kind of contracts they have today or what don't they have? Yuvo's operation is designed to really leverage the aggregation of membership, engage peers, receive these contracts that we've described as bringing incentives onto them. So whether it's the shared savings upside to them, whether it's the care coordination fees that we pass through to them, what is the resources that we deploy to them? All of these are designed to support and make sure that we can lift up FQ. So from a contractual standpoint, Yuvo is positioned to support an FQ such as the one that is described to be able to ingest the right kinds of contracts within the right state and walk them through the right journey so that they can get to the highest levels of risk arrangements and really begin to win in this environment. But we don't do it in oblivion. We do it with guardrails to make sure that they're going to succeed, that they're not at risk, and that we can deploy the solutions, whether it's technology infrastructure, whether it's a human capital, to ensure that they can associate themselves and engage the levers of population health and really be able to succeed. That's where it starts from, assessing, supporting, ingesting contracts. And then Dr. Laura Council can talk about the solutions that we deploy, the clinical solutions, the quality solutions, and all the other levers that we embed and support the FQs with in order for them to thrive in value-based care.
Right. Let's remember that, primary care in the majority of places is not profitable either, right? It's just that in FQs, there isn't another line of business where you're trying to cross-subsidize in a broken fee-for-service system. You're just losing money without the cross-subsidy. So, if your FQ is not profitable in a fee-for-service system, that's probably because they're trying to practice value-based care in a fee-for-service system, and you're never going to win in that way. You're only going to win if you practice value-based care in a value-based care way. Now, for example, your docs may at that FQ have to spend 45 minutes with a patient who just got out of the hospital, and because they spent that 45 minutes, that readmission is prevented, generating value for the health plan and for that patient and for that family. But you're only getting reimbursed the same way as you'd get reimbursed if they stubbed their toe, right? So that doesn't seem reasonable to us. What we would want to do is make sure that we have easy tools at the point of care to capture the complexity of the patients that you're serving already without extra clicks or going into another module or logging into a portal, without telling the docs that it's solely their responsibility to become expert coders, right? We want the whole team engaged in this. We also know that because your FQHC has a grant for this and a grant for that and a grant for the other thing, that they are very distracted on who exactly should be getting what for which patient and who's eligible for who. Overall, the healthcare system has about 30% waste in it, right? And that waste is any time when human capital and human action is spent on things that aren't providing direct value to the patient or family. And so when you streamline the ways that you're getting paid, you can streamline your team operations and you can get rid of that 30% of waste, therefore creating value for the patient and winning, on your own bottom line.
And
Lauren?
yeah, if I can, Blake, since this is hospitality, I know you have these numbers right next to you. So who were some of the biggest profit earners in the first quarter of 2023?
Like by margin or by just sheer number?
Sheer number. Let's go with sheer number.
I mean, United Health, the insurers.
Okay. Yeah. So here's part of the dynamic. We have built our system around price escalation being the norm. And there are elements of our health system that are making money, but not achieving the outcomes. And that's where the policy pressure comes in. So if you want the answer to, I'm an FQ, we've never been in the black, the reason is you are disadvantaged in that system. And so the people making the money aren't the folks at the community level. And essentially what we're doing is we're subverting that dynamic in a way that advantages both the payers on that side of the equation, but also the community-based providers on that side of the equation, because we're taking out the inefficiencies of the system and leveraging the new value-based arrangements that are built around outcomes that are already being achieved at that level. And what we're offering is just the conduit to be able to get there at scale.
Yeah, that makes a lot of sense. And thanks to the entire team for answering that question pretty comprehensively. So I have a just kind of more, I guess, maybe like competitive question. I'm curious because, you're fulfilling like a great need and a great service for FQHCs as far as, value-based care enablement and those sorts of things. What would your answer to the question be if, like, let's say another enablement player all of a sudden, some, publicly traded player or someone else was like, we want to enter FQHCs as a future kind of growth model, hypothetically. Like, how would you kind of answer as far as like what your differentiating factor is versus like a more kind of maybe mainstream player?
Oh, sure. One, just before, I highly encourage anyone to support FQHCs. The more people that are supporting FQHCs, the better. The more people that are supporting the populations that the FQHCs serve, the better. It's just plain and simple there, right? We want more people. We want more money being funded towards innovation to support the communities that are being served by FQHCs. We'll stop. To that question, what's the differentiating point, right? So how we think about it for us is that, again, we were built specifically for federally qualified health centers. We are not a piece of technology. Certainly we are technology enabled, but we are not a piece of technology. We do not just drop off to the FQ and then force them to take on risk and do everything and lead everything on their own. We are very much so a direct hand-in-hand partner with our FQHCs, right? Where we then are, and we think about this as what are ways that we can kind of envelop around those FQHCs to be that connective tissue to the rest of the healthcare ecosystem, and then also find ways for them to get paid more across numerous levers, but under the guidance of value-based care. So when you think about that, I really do think that that is different than, say, value-based care enabling organizations that have popped up a lot, particularly in the Medicare space, right? Because in those situations, and they are amazing organizations, they're relatively light, right? The providers are the ones that are still taking on the risk, right? They're just enabling those providers to take on that risk. And that's very uniquely different than what we have to do, right? Because our FQHC partners cannot take on downside risk. So we by nature have to be that risk-bearing entity. And I would say that's probably the sole, like the biggest differentiator. And in order for us to be a risk-bearing entity, there's a lot of infrastructure that we, again, by necessity, have to build in order to enable that.
And great responses are. And I think that there's just a quick question on, do you happen to know the name of the regulation that prohibits that downside risk for FQHCs?
I don't know the actual name of the regulation. We can go back and maybe, like, if there's a listserv, we're happy to share that. Yeah. But essentially, the rule of the law is FQHCs get paid an encounter rate called the prospective payment system, under prospective payment system, and that is an enhanced Medicare or Medicaid rate, but it is non-risk adjusted for the encounter. Right, so it's a bundled rate for the encounter and all services that are provided there, and it is an enhanced rate mainly because it's meant to subsidize for uncompensated care for uninsured individuals, right? So because they're getting an enhanced rate, then the guidance is essentially they are not allowed to put that enhanced rate at risk. The opportunities that may exist then are there may be alternative payment models that exist within a specific state wherein they get paid more than that PPS, and if they get paid more than that PPS, then the delta is allowed to be put at risk, but the actual PPS is not allowed to be put at risk. They're not allowed to make less than their PPS, essentially.
Okay, interesting. There was one more question. Let me see if I can track it down. Where is it? Sorry, you guys have been asking so many questions. I'm trying to look for the one. Yes, this event will be recorded, first of all. It is being recorded. Let's see. I guess I lost it. Well, either way, we'll send a follow-up email with any, if anybody else has any questions. I think Lauren has dropped in his email into the chat. And Yuvo Health team, I'd love for y'all to share just, any ways that folks can stay connected to y'all. Lauren, I don't know if you wanted to take that or.
I'll start. I would definitely encourage folks to check out our website at yuvohealth.com. We have different policy briefs. We have a newsletter that we just launched, and feel free to sign up to stay connected with us generally. I also put my personal email in the chat. If you want to learn more, if you want to get connected with us, if you're an FQ or you're part of a trade association or you're someone who works with a lot of FQs and you're like, this sounds pretty interesting to us, let's have a conversation. We can get a little bit deeper and talk a little bit more. Or if you just want to walk out a Medicaid policy, I'm happy to do that too. But I think those would be the two main things to stay on the lookout for. And our website is the best way to stay regularly connected, but always feel free to email.
Yeah, thanks, Lauren. And again, we'll share a follow-up email with the attendees, and I'll also share a webinar recording to the broader hospitality audience. So, but yeah, I wanted to, kind of wrap up. Did anybody have any kind of closing thoughts before I kind of give the final spiel?
So I'd love to encourage everybody on the call to find out what's the FQHC closest to you. Where's the one where you live and in your neighborhood? How's your corner of the health ecosystem connected to that FQHC? Are they being included or left out? And if they are being left out, what do you want to change? What can you change tomorrow where you work to reach out to them and to start weaving them into the community support that you're providing?
Awesome. Yeah, thanks, Laura. And again, thank you to the entire Yuvo Health team for joining this conversation. I think it was really interesting. You guys know where to find them if y'all have any more nuanced questions. And thank you to Doc Health for sponsoring this webinar. I think y'all will be hearing more from them soon as well. Someone to keep on your radar. And yeah, for anyone else who's interested, I also have a community of healthcare execs for folks that are interested in learning more. Feel free to get in touch with me. And, I think I'll let y'all go a little early and, have a good rest of your Tuesdays. And it was a great conversation. So thanks everyone for joining.
Appreciate everyone's time.
Thank you, Blake.
Thank you so much.
Thank you, Blake, for your time. Bye.